Good morning, sir. Good morning, Ravi.
Good morning, madam.
Good morning, ma'am. ఇక్కడ జాయిన్ అవుతున్నారు అంటారా?
ఎంతమంది అయినారా?
9 మంది.
ఆన్ చేసాను చూడరా. ఒక నిమిషం. టెన్ ఉన్నారు సార్.
శ్రీకాంత్. హలో
సార్ ఫోన్ బిజీగా వచ్చింది సార్.
లేదు, లైన్లో జాయిన్ అయి ఉన్నాడు, కనపడుతుంది లోపల.
కిరణ్ కుమార్ వచ్చారు సార్. స్టార్ట్ చేయాలా సార్? మనం అన్మ్యూట్ చేస్తాం. సార్ స్టార్ట్ చేయాలా సార్?
శ్రీకాంత్ లేడా లైన్లో?
లేదు సార్.
హలో శ్రీకాంత్, లైన్లో ఉన్నాడు మరి?
సార్ వాయిస్ వినపడటం లేదు సార్.
సరే అయితే స్టార్ట్ చేయి.
Good morning. Today my topic is thoracic anesthesia. Most of the cases presenting for thoracic surgery have bronchial carcinoma, mediastinal masses, or esophageal diseases. Respiratory complications are the major causes of perioperative morbidity and mortality in thoracic surgery patients. History of smoking and symptoms suggestive of COPD and ischemic heart disease should be elicited. History of chemotherapy, lethargy, weight loss, anorexia, medical history of coexisting diseases also elicited. History of bronchopulmonary symptoms such as cough, wheeze, breathlessness are the most common complaints experienced by these patients. In preoperative evaluation, on examination, the patient is using axillary respiratory muscles, tachypnea are noted. On palpation, medial channel shift is noted. Whether medial channel shift is not present or not noted. On percussion, overall assessment of the severity of lung diseases indicate the presence of consolidation, atelectasis, or pleural effusion.
కొంచెం వాయిస్ పెంచవారు అవి.
సార్ ఇప్పుడు వినపడుతుందా సార్? హలో సార్.
ఏం లేదు, కొంచెం గట్టి చెప్పు, వినపడుతుందిలే.
On auscultation, additional sounds such as ronchi, crepes are noted. Decreased entry or equal entry in different areas of chest are noted. Investigation, there are baseline investigation, special investigations. In CBC shows anemia, polycythemia, leukocytosis. Baseline investigations such as RBS, LFT, and RFT involve corresponds to the age of the patient. Chest X-ray shows a tracheal deviation of obstruction, signs of pleural effusion, signs of pulmonary edema, atelectasis, and consolidation. ECG shows ischemic changes and right and left side heart dysfunction. CT scan shows which part of the lung is involved and to what part extent the lungs are involved. It helps in determining the size of double lumen tube. Baseline ABG in COPD patients is baseline ABG shows carbon dioxide retention and low levels of PaO2. In echocardiography shows right ventricular dysfunction occur in 50% of patients of COPD. 30 to 40% of patients with post-operative pneumonectomy also shows right ventricular dysfunction. Recurrent hypoxia is main cause of right ventricular dysfunction, which increase pulmonary vascular resistance. Baseline spirometry is needed in all patients. Respiratory function assessment involves respiratory mechanics, ventilation, cardiopulmonary exercise, ventilation perfusion scanning. Respiratory mechanics measures FEV1, FVC, mean volume ventilation, residual volume, total lung capacity, and from FEV1 we will calculate predicted post-operative FEV1. Based on the predicted post-operative FEV1, the formula is preoperative FEV1 percentage into 1 minus functional lung tissue removed by 100. If predicted post-operative FEV1 is greater than 40%, there is low risk of post-operative morbidity or mortality. If it is less than 40%, high risk of morbidity. Less than 35%, very high risk of mortality. That is 10 out of 10 patients may go to or 6 out of 10 patients cause death. Lung parenchyma function is assessed by using diffusing capacity of carbon monoxide. Predictive post-operative diffuse lung for carbon monoxide is less than 40%, means there is high chance of perioperative mortality. Cardiorespiratory assessment done by exercise testing, maximum oxygen consumption, stair climbing test, 6-meter walk test. In maximum oxygen consumption is less than 15 ml per kg per minute. That implies fall in SpO2 4%, which mentions high risk for thoracotomy mortality. If maximum oxygen consumption is less than 10 ml per kg per minute or climbing less than 2 flights of absolute contraindication resection. Ventilation perfusion scintigraphy assess contribution of part of a lung or a lobe to be resected in ventilation and perfusion. It should be done in all patients posted for pneumonectomy, and preoperative FEV1 or diffuse lung capacity for carbon monoxide less than 80% is an absolute contraindication for pneumonectomy. Minimal preoperative measurements are predictions of sound. I mute there.
వాయిస్ వినపట్లేదు, వాయిస్ ఏదో కట్ అయిపోతుంది.
అదే సార్, ఇంకా చెప్పలేదు సార్, డిస్టర్బెన్స్ అని ఆపాను. అది సార్ వాళ్ళని మ్యూట్ చేయాలి. అది మ్యూట్ చేస్తాను.
అతని కాంటాక్ట్ అడుగు, అతని కాంటాక్ట్ అడిచి ఎందుకు ఇలా అవుతుందో బషీరుద్దీన్ అడుగు.
సార్ ఇక్కడ కంట్రోల్ చేయడానికి రావడం లేదు సార్. సరే నెక్స్ట్.
నీ సిగ్నల్ ప్రాబ్లం ఉందా?
లేదు సార్, సిగ్నల్ బాగానే ఉంది సార్, ఇప్పుడు ఆపాను సార్.
అందుకోసం ఇప్పుడు బాగానే ఉంది, అదేదో ప్రాబ్లం వస్తుంది దానిలో, ఎందుకో అంతే.
ఇందాక వేరే వాళ్ళు స్పీకర్ మ్యూట్ చేయలేదు సార్. Minimal preoperative measurements are predictions of for various size pulmonary dissections, sir. If diffuse lung capacity for carbon monoxide is greater than 60, it should be greater than 60% for pneumonectomy. For exercise testing, it should be greater than 5 flights for pneumonectomy, greater than 3 flights for lobectomy, greater than 2 flights for segmental dissection. Maximum oxygen consumption should be greater than between 1 to 3% of 3 liters per minute. For pneumonectomy, 1 to should be greater than 1% and less than 5% for lobectomy. Greater than 1% and less than 5% for segmental dissection. In ABG, PaO2 should be greater than 80% for pneumonectomy and greater than 70% for lobectomy, greater than segmental 60% for segmental dissection. PaO2.
సారీ ఫర్ డిస్టర్బెన్స్. బాగానే ఉంది, వినపడుతుంది, మాటలు వినపడుతున్నాయా?
సార్ ఏమి వినపడడం లేదు సార్.
సరే, థ్యాంక్ యూ.
అన్ని చేయాలి సార్,
ప్లీజ్ ప్లీజ్.
PaO2 should be less than 45 for pneumonectomy, less than 50 for lobectomy, less than 55 for segmental dissection. There is a 3-leg stool of pre-thoracotomy respiratory assessment, as we discussed now. Summarize for respiratory mechanics, required parameters are FEU1 should be greater than PPO greater than 40%. Other parameters are minute volume ventilation, residual volume, and total lung capacity, forced vital capacity. For cardiopulmonary reserve, maximum volume oxygen consumption should be greater than 15 ml per kg per minute. Stair climb should be greater than 2 flights. 6-minute walk. Exercise saturation should not fall less than 4%. For lung parenchymal function, diffuse lung capacity for carbon monoxide, it should be greater than 40%. PaO2 should be greater than 60. PaCO2 should be less than 45. There are two most important side effects in these patients. They suffer in perimortem, perioperative period, which are ischemia and arrhythmias. Ischemia can be avoided by preoperative measurement with echocardiography, angiography. It can be prevented by continuing of beta blockers preoperatively on the day of surgery. Arrhythmias can be hindered by applying thoracic epidural anesthesia perioperatively. Other drugs used are diltiazem, beta blockers, verapamil, amiodarone. Digoxin is of no use in perioperative arrhythmias. It is a flow chart for elderly patient greater than 60 years, whether the patient is fit for lung resection or thoracic surgery. Transthoracic echocardiography rules out pulmonary hypertension. If there is excellent exercise tolerance along with absence of pulmonary hypertension and no history of coronary artery disease or diabetes or congestive heart failure, patient can undergo lung dissection surgery. If there is pulmonary hypertension and moderate or poor exercise tolerance or history of coronary artery disease or diabetes or congestive heart failure, patient next step is dopamine stress echo or thallium scan test or myocardial perfusion imaging. If the imaging shows low risk, then lung dissection surgery patient can undergo lung dissection surgery. If imaging shows increased risk, next step is coronary angiography. If the candidate is shows thrombosis, then surgical revascularization should be done before surgery, based on case specific. If angiography is negative, cardio surgery is not needed, and the patient can undergo lung dissection surgery. Anesthetic considerations for patients who are having cancer, there are four M's. Mass effects, example, tumor block effect, superior vena cava syndrome, pan post tumor syndrome, paraneoplastic syndromes. Then based on metastasis, also different other comorbidities also occur. Metabolic effects such as electrolyte imbalances, hormone imbalances may occur. Medications side effects due to chemotherapy are seen in cancer patients. In patients with COPD, there is a decreased respiratory drive in stage 2 and stage 3. There is nocturnal hypoxemia, right ventricular dysfunction, bulle, and autopeep. Preoperative preparation. These patients require very low dose of pre-medication drugs to avoid hypoxemia or narcosis. They are prone to develop more prone to develop post-operative complications. Hence, the pre-existing pulmonary diseases should get optimized before surgery. Smoking cessation. At least the patient should, for elective surgeries, patients should stop smoking at least 8 to 12 weeks. If it is an emergency surgery, a semi-elective surgery, at least 72 hours, the patient should stop smoking. As it decreases carboxyhemoglobin levels and ciliary function improves. And by 1 to 2 weeks after cessation, there is decreased sputum production. By 4 to 6 weeks, pulmonary function tests improve. Airway dilatation is needed for patients who have hyperactive airways such as smokers, asthmatics, or COPDs. It is done by use of inhaled beta-2 agonist, ipratropium bromide, especially in COPD patients. Steroids, inhaled or IV. Effect of bronchodilation is qualified by subjective feeling of relief and pulmonary function test. Thick secretions are usually loosened by adequate hydration using humidifier or ultrasonic nebulization. The secretions are then removed by postal drainage, coughing and chest percussion and vibration for 15 to 20 minutes several times a day. Chest physiotherapy removes secretion from peripheral airway to central airway. Force expression technique causes better clearance of secretion than cough. Chest infection, if present, should be treated by adequate antibiotics, appropriate antibiotics according to culture and sensitivity. Measures to increase motivation and post-operative care are nutrition improvement, weight reduction in obese, psychological preparation, and instructions about incentive spirometry, chest physiotherapy, and postal drainage. Next is after adequate optimization, OT plan is online ventilation, where the means separation of two lungs and each lung functioning independently by preparation of the airway. The lung which is getting operated is collapsed, and the other lung is on the dependent side. One lung ventilation provides protection of healthy lung from infected or bleeding one. Diversion of ventilation from damaged airway or lung improves exposure of surgical field. One lung ventilation causes more manipulation of airway, more damage, significant physiological change, and easily development of hypoxemia occur. Absolute indications for one lung ventilation are isolation of one lung from the other to avoid spillage or contamination, to avoid infection, to avoid massive hemorrhage, control of the distribution of ventilation in bronchopleural fistula, bronchopleural cutanous fistula, surgical opening of major conducting airway, giant unilateral lung cyst or bulla, tracheobronchial tree destruction, life-threatening hypoxemia due to unilateral lung disease. Methods of one lung ventilation are double lumen endotracheal tube, single lumen endotracheal tube with a built-in bronchial blocker, inuvent tube, single lumen endotracheal tube with an isolated bronchial blocker, balloon tip lumen catheters, and wire guided endotracheal endobronchial blocker set, endobronchial intubation of a single lumen ED. Preoperative anesthetic management. Preoperative epidural catheter placement is a good standard. It avoids uses of IV narcotics. It decreases requirement of anesthetic agent. It is helpful for post-op analgesia. Double lumen tube is preferred. It is a gold standard. There are two types of double lumen tubes, right and left sided. Rubber shot tubes are most common. Other tubes are rush double lumen tube, Carlin double lumen tube. These are designed with the bronchial lumen that has its own cuff and extends distal to the carina, which takes 3 ml air. The tracheal lumen has its own cuff that inflates proximal to carina, which takes 8 ml air. Double lumen tubes come in several sizes: 26, 28, 32, 35, 37, 39, 41 French. Inflatable bronchial cuffs are bright blue. Few double lumen tubes has carinal hook to provide a proper placement. Margin of safety, depending on the length of the lumen into which cuff is placed, and it depends on the length of the lumen into which cuff is placed and length of the cuff. If the cuff is short or the main stem bronchus is long, margin of safety will be more. Outermost acceptable position is bronchial cuff is just below the carina. Distal acceptable position is bronchial segment tip is at proximal edge of upper lobe bronchial orifice. Margin of safety for right side double lumen tube are less than left side double lumen tube. Correct size of double lumen tube based on the height and sex varies. In females, less than 152 centimeters, size is 32. Greater than 160 centimeters, size is 37. In males, less than 160 centimeters, size is 37. In males, greater than 170 centimeters, size is 41. Left side double lumen tubes are preferred over right side double lumen tubes because they are hard to place because of short right main stem bronchus. Right main stem bronchus is 2.22 to 2.3 centimeters versus left main stem bronchus is 5.4 centimeters. Right indications for right double lumen tube are distorted anatomy of the entrance of left main stem bronchus, external or intraluminal tumor compression, narrowed left main bronchus, descending thoracic aortic aneurysm, site of surgery involving the left main stem bronchus, left lung transplantation, left sided tracheobronchial disruption, left side pneumonectomy, left side sleeve resection. Hazards associated with double lumen tubes are deflate the cuff when repositioning the patient, not too much advance the tube when too much resistance is encountered. Bronchial cuff is deflated until it is necessary to inflate. Surgical complications occur. Bronchial cuff may be punctured or suture taken by surgeon. Failure to seal due to malposition or improper inflation of cuff. Physiological considerations of lateral decubitus position. In awake, there is a decreased ventilation in dependent position and increased perfusion in dependent lung. As a patient undergoes converts from spontaneous to anesthetized, the further ventilation perfusion matching increases more than the awake position. In awake spontaneous closed chest position, Ventilation increase in dependent lung. Diaphragm of the dependent lung push higher and stretch greater. 60% of blood will flow through the dependent lung, 40% flowing through the non-dependent lung. Because total shunt is roughly equally divided, that is 10% of cardiac output, 55% and 35% cardiac output participating gas phase change respectively. So ventilation perfusion will be better in awake position and spontaneous closed chest position. Blood flow increase more rapidly than ventilation. So ventilation perfusion will decrease from non-dependent to dependent lung. In lateral decubitous position, awake spontaneous open chest. Opening the chest of a patient in the lateral decubitous position can cause two additional changes. First, both of which result from the intact hemothorax ability to generate negative pressures. The mediastinum may shift towards the closed hemothorax, possibly resulting in disastrous hemodynamic changes, that is mediastinal shift. Second is the closed hemothorax lung may remove air from the open hemothorax, leading to paradoxical breathing. In anesthetized spontaneous open chest position, opening the chest of an anesthetized spontaneously breathing patient result in medial shift and paradoxical breathing, but also further increases the ventilation perfusion mismatch that occurs in anesthetized patients due to changes in ventilation, mainly not due to perfusion. In anesthetized paralyzed open chest position, paralysis implies in positive pressure ventilation, which further worsens ventilation perfusion mismatch as gas moves preferentially into non-dependent lung, mostly due to decreased abdominal resistance, but potentially due to the open chest. Advantages of lateral decubitous position are it permits most complete access to hemithorax. Length of incision can be easily extended. Patient can be tilted forward or backward easily. Safest position for hilar dissection. Permits control of hilar vessels. Disadvantages are opposite hemithorax is inaccessible. Ventilation perfusion mismatch is more. Contamination of dependent lung. Decreased functional residual capacity. Airway closure and atelectasis in dependent lung occur. Injury from positioning also occur. Hypoxic pulmonary vasoconstriction is a local response of pulmonary artery smooth muscle. It is an auto-regulatory mechanism. It decreases blood flow to the area of lung where a low alveolar oxygen pressure is sensed and protects the PaO2 by decreasing the amount of shunt flow that can occur through the hypoxic lung. Here, vascular smooth muscle causes calcium channels opening, so that it causes contraction of vascular smooth muscle, causing vasoconstriction. The mechanism is not completely understood. Vasoactive substances released by hypoxia or hypoxia itself cause pulmonary artery muscle smooth muscle contraction. It aids in keeping a normal ventilation perfusion relationship by diversion of blood flow by 50% from underventilated areas. It is graded and limited and of greatest benefit when 30% to 70% of lung is made hypoxic. It has rapid onset in first 30 minutes. Factors affecting regional hypoxic pulmonary vasoconstriction are distribution of hypoxia, low ventilation perfusion, vasodilators such as nitroglycerin, sodium nitroprusside, dobutamine, many beta-2 agonists, calcium channel blockers, anesthetic drugs, increased pulmonary vascular resistance as in mitral stenosis, myocardial ischemia, pulmonary embolism, and pulmonary hypocapnia. Then it is indirectly inhibited by low PVO2, pulmonary venous oxygen, and pulmonary vascular resistance, low FiO2, and PEEP vasoconstrictor drugs. Factors that increase risk of desaturation during one lung ventilation are high percentage of ventilation or perfusion to the operative lung on preoperative scan, poor PaO2 during two lung ventilation, particularly in the lateral position intraoperatively, right-sided thoracotomy, normal preoperative spirometry, that is in restrictive lung disease, supine position during one lung ventilation. The use of nitrous oxide oxygen mixture is associated with a higher incidence of post-thoracotomy radiographic atelectasis in the dependent lung than when air and oxygen mixture are used. There is increased pulmonary artery pressure in patients who have pulmonary hypertension. Nitrous oxide inhibits hypoxic pulmonary vasoconstriction. It is contraindicated in patients with blebs or bullae. For these reasons, nitrous oxide is usually avoided. Ventilating parameters for one lung ventilation are tidal volume suggested is 5 to 6 ml per kg. PEEP is 5 centimeters water in patients with COPD. No PEEP is added. More respiratory rate is 16 to 18 per minute to maintain normal PaCO2. Mode is either volume or pressure mode. Pressure control for patients at high risk of injury is preferred. Peak airway pressure should be maintained less than 35 centimeters water. Plateau airway pressure should be less than 25 centimeters of water. Principles of fluid management. Total positive fluid balance in the first 24-hour perioperative period should not exceed 20 ml per kg. For an average adult patient, crystallite administration should be limited to less than 3 liters in the first 24 hours. There should be no fluid administration for third space fluid losses during pulmonary resection. Urine output greater than 0.5 ml per kg per hour is unnecessary. If increased tissue perfusion is needed post-operatively, it is preferable to use invasive monitoring and inner drops rather than to cause fluid overload. Early major complications are respiratory failure. It is the most common cause of morbidity after thoracic surgery. Definition is PaO2 less than 60 mmHg, PaCO2 greater than 45 mmHg. Use of post-op ventilation for greater than 24 hours. Reintubation for controlled ventilation after extubation. Pulmonary edema is another major complication. Causes are endothelial injury, which increased capillary permeability, capillary pressure, lymphatic damage, lymphatic damage, lung hyperinflation, fluid overload, right ventricle dysfunction, oxygen toxicity. Treatment is mechanical ventilation with PEEP, restriction of fluids, and diuretics. Mechanical ventilation and weaning planning. The primary goal is PEEP titration, then decrease FiO2, then decrease IMV rate. PEEP titration should be based on PaO2 greater than 60 mmHg. PEEP can be decreased to 10 centimeters of water, and FiO2 can be decreased to less than 0.5. If PaO2 is greater than 60 mmHg, IMV should be and FiO2 is less than 0.5. IMV should be decreased to less than 1 breath per minute. Post-thoracotomy anesthesia management. Based on the predictive post-operative, it is based on predictive post-operative FEV1. If greater than 40%, patient is awake, alert, warm, and comfortable, patient can be extubated in operating room itself. If PPO, predicted post-operative FEV1 is in between 30 to 40%, check for exercise tolerance, diffuse lung carbon monoxide, ventilation scan preoperatively, and associated diseases. Then after if it is greater than you can based on these parameters you can extubate. If PPO FE1 is greater than 30%, staged weaning from mechanical ventilation is considered. If plus thoracic epidural anesthesia is also needed. Assessment and intensive respiratory care management. Aggressive and intensive respiratory care regimen are needed for removing secretions such as coughing routines, tracheal suctioning, fiber optic bronchoscopy, chest percussion and vibration. All the above aided by posture and turning frequently. Thank you. Madam?
చెప్పు రవి, రెండోదా లైన్ లో ఉంది కదా.
అయిపోయింది సార్.
Thank you, Ravi. Any questions from the audience?
థ్యాంక్ యూ మేడం.
Good morning. Ravi, how do you confirm the correct position of the DLT?
Sir, first we'll make tracheal cuff inflation, sir. Then we'll check bilateral air entry, sir. Then after that, we'll clamp tracheal cuff. Then we'll inflate bronchial cuff. Then we'll check unilateral ventilation, sir.
If advanced monitoring is instruments are available, what will you do?
Advanced fiber optic, sir.
Yes.
Okay. Fiber optic bronchoscope, we will go and confirm the position, sir. Undersized fiber optic bronchoscope.
What
While doing-
undersigned fiber optic, Ravi? And how to introduce the DLT also, please explain.
There are two bends in DLT, madam. One at tracheal cuff side and another at bronchial cuff side. Both are 90 degrees having a 90 degrees angle, madam. First we will insert the cuff until tracheal cuff enters the glottis. After that, we will rotate the cuff towards 90 degrees. That side.
there are two curves, orobronchial curve and tracheobronchial curve. So you keep the tracheobronchial curve concavity upwards
Okay.
and introduce till it passes through the larynx. Then turn to which side you want.
Sir.
While during surgery, how do you test for there is no air leakage of the stump? After pneumonectomy or lobectomy, the surgeon asks to do something. What is that? To test the air leak. You fill the cavity with a normal saline. The surgeon will ask you to give a peep. If there are no air bubbles, the suture is tight.
Okay.
Do you keep intercostal drain for pneumonectomy or lobectomy? You are doing a night duty and there is an intercostal drain. When will you caution the surgeon?
More amount of bleeding, sir.
How much? More than 100 ml for 2 consecutive hours or more than 200 ml in a single hour. During surgery,
200 ml, sir. Raman Prasad, sir, more than 200 ml.
Sir, 200 ml in single hour or more than 100 ml for 2 consecutive hours. During operation, there is hypoxia. What will you do? With double human tube, you are giving anesthesia for pneumonectomy.
The strategies are these, sir. First, we'll convert double human tube, that single lung ventilation to double lung ventilation, sir. Then we'll supply 100% oxygen. Then PEEP is increased, sir. CPAP for dependent lung, non-dependent lung, PEEP for dependent lung, sir.
First, you will check the position of the tube. Then you will suck the tube for any secretions. Then you give the CPAP 5 to 10 centimeters for non-dependent and PEEP of 5 to the dependent lung. Still not improving, you will ask the surgeon to quicken the surgery, and also you will remove the DLT and convert into a single lumen. Other than epidural analgesia, what are the post-operative techniques for analgesia?
Sir, paravertebral block, erector spinal block.
Cryoanalgesia, did you heard? It was a short notes previously.
Xenon, sir.
Huh?
Cryoanalgesia.
No. Intercostal block also.
Intercostal.
Surgical lobes ఎన్ని ఉన్నాయి నేను మర్చిపోయాను కానీ ఇది క్వశ్చన్ అడుగుతున్నా. How many surgical lobes you would have?
Sir, 10 to 12, sir. 10 on left. 10 on left.
అవి సర్జికల్ లోబ్స్ కాదు.
Anatomical lobes.
42 అనుకుంటా.
42. అవి segmental lobes, sir. అంతే. Bronchopulmonary segments. 22 on right side and 20 on left side.
అంటే నువ్వు ఫిజియలాజికల్ అమౌంట్ ఆఫ్ లంగ్ టిష్యూ FE1 ప్రిడేటివ్ పియోపరేటివ్ FE1 లో
సార్ 1 మైనస్
అక్కడ వేయాలి 42 మైనస్ ఎంత అమౌంట్ రిమూవ్డ్. వాట్ ఆర్ ది బెడ్ సైడ్ టెస్ట్ ఫర్ టు నో ది కార్డియో రెస్పిరేటరీ రిజర్వ్?
సార్ మ్యాచ్ బ్లోయింగ్ స్టిక్, సార్.
Snyder's
Snyder's math blowing test.
ఇంకోటి breath holding test of Sabra-Sech and forced expiratory flow time.
40 seconds.
What is the normal maximum breath holding time?
40 seconds, sir.
When will you say not fit?
Less than 20 seconds, sir.
What is the name of the W tube that has a hook?
Carlin, sir.
Yes.
కాదు రవి, ఎరెక్టర్ స్పైనల్ బ్లాక్ ఎలా ఇస్తారు?
Sir, patient on the patient on right lateral position, sir. Then sir, from nuchal prominence, sir, sitting position, sir. We'll count the vertebra from C7 prominence to T12, sir. On the paraspinal area, 1 inch. We'll go, sir.
Where is the bronchial blocker? Uses of bronchial blockers.
చెప్తున్నాడు కదా, చదివా అసలు ఎప్పుడైనా ఎరెక్టర్ స్పైనల్ బ్లాక్?
మొన్న వర్క్ షాప్ లో చూసాను సార్, మర్చిపోయాను.
మర్చిపోతే ఎలాగా ఎగ్జామ్ లో కూడా ఇదే చెప్తావేంటి ఎక్స్టర్నల్ కి? పారావర్టిబ్రల్ బ్లాక్ ఎలా ఇస్తారు? When you are saying thoracic anesthesia in current day scenario, facial plane blocks నీకు డెఫినెట్ గా రావాలి. How do you give landmark guided and how do you give ultrasound guided? ఖచ్చితంగా పడతాయి 2 క్వశ్చన్లు నీకు అనాలిసిస్కి. చదువుకో 2. Okay, sir. That's all from my side.
Ravi, bronchial blocker uses ఏంటి?
Sir, single particularly we can block that single segment, sir.
No, it is used mostly in pediatric age group and also for fulminant to tamponade the bronchial hemorrhage, pulmonary hemorrhage. What do you prefer, right or left DLT, and why?
Left, sir, because of the long left bronchus, 5 centimeters, 5 to 5.4 centimeters from the left upper main bronchus, sir. Bronchi to the carina junction, sir. There is less chance of blocking the left upper lobe when compared to right upper lobe.
Your answer is correct, but you are more appropriate when you say margin of safety is more with.
As a margin of safety.
కొన్ని words padali when you are answering.
Ravi, single human tube and bilateral blockers చూసావా? రీసెంట్ గా వచ్చింది. So single human with you can introduce the blocker that contains right side and left side. So you can introduce that blocker. It will go to the right side and left side. Which side you want isolate, that side you can isolate. No need to use a DLT.
Okay.
What are the indications for PA catheter in pneumonectomy?
To assess pulmonary arterial hypertension, sir.
Yes, good. How do you treat pulmonary hypertension? Sildenafil.
Sir. Nitric oxide.
Nitric oxide also inhalation.
Ravi, you introduce DLT.
Yes.
So bilateral check by everything is okay. Suddenly, chest not rising. How to rectify?
Both sides, sir.
Both sides is not ventilating. Bag is too much of tight.
And first we have to check whether the tube is open on at the proximal end, madam. Then we have to confirm whether it is in esophagus or trachea, madam.
How to rectify that problem? After position, it's chest not rising, back too tight.
Spasm is there, madam. Bronchial spasm or
No,
lateral.
you have to
Not spasm.
withdraw the tube. It has gone too far.
Okay.
Madam, correct?
What happens, sir? Bronchial cuff also comes out, and some amount is blocked the right side also. I mean, other side also. So that's why you are unable to ventilate the opposite side lung. So if you have intubating bronchoscopy, how to rectify this problem?
Deflate the bronchial cuff, madam. Then we have to further go inside the tube in deeper, madam.
How do you know that bronchial cuff comes outside? So during a intubation bronchoscopy, what are the things you want to see?
Fiber optic, madam. We'll confirm with the bronchial cuff position, madam. Whether it is at the junction of the bifurcation or whether it went into the bronchus.
What is the color of bronchial cuff and what is the color of tracheal cuff?
Bronchial cuff blue, madam. Tracheal cuff is transparent, madam.
How much volume you want to inflate in bronchial cuff?
3 ml, madam.
Sir, any questions, sir?
While doing bronchoscopy, what is the first part visualized?
Cartilage arches and arches, sir. Pathways, what is it? Road stripes.
Tracheal rings antava.
కాదు సార్ బ్రాంకియల్ పాత్వేస్ ఉంటాయి సార్ కింద ట్రాక్స్.
దానికంటే ముందు ఫస్ట్ యూ విజువలైజ్ ది కెరైనా.
కెరైనా.
Ravi, how do you know this is left side and right side?
Madam, at the junction of at the carina on the right side, after crossing the right upper lobe bronchus, there is a very short distance where we can easily visible the diverse bifurcation of right middle and lower lobe bronchi bifurcation.
Repeat again.
కెరీనా దగ్గరకు వచ్చినాక రైట్ సైడ్ కు మిడిల్ లోబు లోయర్ లోబు బైఫర్కేషన్ ఈజీగా విజిబుల్ అవుతుంది మేడం లెఫ్ట్ సైడ్ కన్నా.
So that is the answer.
తెలియదు మేడం, నాకే తెలియదు.
I mean, right side means right upper lobe also you can see, no?
ఫస్ట్ అది చూస్తాం మేడం, తర్వాత
అది కష్టము, దాన్నే చూడడమే. సపోజ్ యు ఆర్ సీయింగ్ ద రైట్ అప్పర్ లోబ్ మీన్స్ యు ఆర్ మోర్ ఎక్స్పర్ట్ ఇన్ bronchoscopy. So you are seeing the right upper lobe also, that means you are right side. In left side you no upper lobe, I mean that separate segments. So You can identify like this,
Oh.
upper, middle, and lower. And because sometimes you are introducing the bronchoscope, no? So up and down positions, so you don't know which side you are going.
Oh.
So make sure you're already your plan for introducing left side. So after that, you can check right side is upper lobe or left, which one is there. Any experience of DLT? Chest not rising and patient on lateral position. Like sir told, no, hypoxia, how to rectify and remove the DLT and introduce the single human.
Only one case I went, madam.
Sir, me experience,
నా అంటే అలా కాలేదు మేడం. ఇప్పుడు చేసాం కానీ 5-6 కేసులు బాగానే అయిపోయినాయి.
నాకైతే ఒక 3 times lateral only I introduced the single human, sir.
మధ్యలో తీసారు మేడం, తీసి సింగిల్ ట్యూబ్ వేసారు.
DLT removed and a single tube kept. One case is bronchial tear. So purposefully I kept a single human because of that time is difficult. I thought is difficult DLT, so I told to surgeon, so single human. That is the luckiest time for me. So actually planned for lobectomy, polytrauma case. So suddenly surgeon opened the lung, suddenly collapsed. Bilateral, I'm not able to ventilate. So I told to surgeon, I'm not able to ventilate, lung collapse, desaturating. So immediately I introduced the blocker and it's gone to right side and told to surgeon to see the blocker and keep which side you want. So immediately he kept blocker and I introduced the blocker cuff. After that only I can inflate the bag. So that means it is gone to bronchial tear. That also one experience.
వెరీ గుడ్.
And same case, plan for extubation. But that time also desaturating or something. So suggested we want to see the bronchoscopy. After that only extubate. So during bronchoscopy also one free flap, I mean a white color mucus layer is flapping into the carina. Already right side gone, pneumonectomy done, and the left side is lung ventilating. That flap is moving.
Herniation of the tracheal cup.
No. That I mean during injury, maybe the tear or something comes. So that is blocking the left side. So that day is postponed, and chest physician came, Dr. Balraj came and saw the thing and removed that layer. After that only we extubated. So first day when I intubate the single human, that is the main luckiest for me. Otherwise I introduced DLT, that layer may be gone to left side and right side bronchial tear, maybe intrap only event will occur that time. No, bronchial tear, no. So right side I am unable to ventilate. If I introduce DLT, maybe this layer gone to left side. Maybe. So 3 times that event's gone, sir. So that girl age 18 years. Any questions? Mohan sir.
లేదు మా ఎక్స్పీరియన్స్ చెప్పావు కదా నీది.
ఇంకా ఉన్నాయి సార్ కానీ చెప్పలేదు.
టైం అయిపోయిందా?
అదేం కాదు సార్, భయపడిపోతాను నేను.
సరే, ఓకే శ్రీకాంత్.
సరే, ఓకే సార్.
ఓకే, థ్యాంక్ యూ శ్రీకాంత్.
థ్యాంక్ యూ సార్. థ్యాంక్ యూ రవి.
థ్యాంక్ యూ రవి, బాగానే ప్రెజెంట్ చేసావు.
Thank you.
థ్యాంక్ యూ సార్.